Hi everybody, and welcome to May I Interrupt, the second season of our slightly irreverent broadcast, talking about all things exciting and interesting in eye care. We're here today live at the American Academy of Optometry, and we're really excited to spend the next few minutes talking to some very influential and interesting person within the eye care field.
Hey Craig, may I interrupt?
Before I get started though, excuse me, what was that?
May I interrupt?
Yes, you can.
I just wanted to talk about how cool our golf balls are, because they are.
Right.
And Scott, who is our guest today, happens to play golf.
Yeah.
So he was quite happy to get his May I Interrupt golf balls.
Oh, that is terrific.
Yep.
You know,
Also, may I interrupt one more time?
yes.
Okay. Don't forget about the water bottles. These are great. I've been drinking out of this the last few days, cleaning it occasionally. And I just want to say that if you love this bottle or the golf balls, please talk to your Oculus rep or contact the company to see if they will send you some, because we really want you to have this fine May I Interrupt merchandise. All right, you go ahead.
Thank you. Jason appears to be done now, so we'll continue with what we planned on doing today.
I'm not really done, but done for the moment.
I was going to talk about influential people within the field and then introduce you until you interrupted, and now you're on your own. His name's Jedlicka.
Well, we don't want to make many mistakes. So
today we have a very interesting guest for our show today, and I know that he's an interesting guest because Jason told me he's a really interesting guest, and so we're going to find out here in a minute. So I'd like to welcome, if we can, Dr. Scott Hauswirth. Scott, come on over. How you doing, man?
Hey, great. Thanks, Craig.
Welcome.
Scott,
Jason.
good to have you.
Thanks for having me. Appreciate it.
Climb up in our fancy chairs here.
These are really fancy,
They
actually.
are.
They're almost as fancy as the golf balls, but
You
Not
can't
quite.
beat the golf balls.
Yes.
You can't beat the golf balls.
So I think I should tell you that the golf balls look great and they have a nice logo,
yeah,
but they're illegal. They have too many dimples.
for real. Then I definitely want some.
Yeah, they go farther.
they're contraband
Contraband.
on the golf course.
Are these
So
German
is
golf
the-
balls? Is that what it is?
Is the Ranger...
They're used on the golf putts
Oh,
in
yeah.
Germany.
Gotcha.
Right.
I definitely don't belong there. That's a dangerous situation.
Yeah. Hey, so Scott, tell us your story. Where are you from?
So, do you want this to be a long story or a short story?
Medium.
Where did you grow up?
Medium.
And did you grow up?
Yeah. I never grew up.
Got that?
I was born in Upper Michigan, but raised in Wyoming, state of Wyoming, and then undergrad at University of North Dakota in Grand Forks, one of the coldest places in the United States.
Good hockey team.
Yeah, great hockey team.
Good hockey team.
Great hockey team. Ended up at Southern California College of Optometry for my optometric education. That brought me to Minnesota with a small ophthalmology practice called Minnesota Eye Consultants, where I did my residency in Jason's shadow.
Yeah.
He had kind of set the bar pretty high.
Very small shadow, by the way,
Well,
due to lack of height.
the sun was high in the sky at the time.
true.
So I followed 2 years behind Jason, and then remained there for 17 years. In the last 4.5 years, I've been at the University of Colorado School of Medicine, where I'm running the Ocular Surface Clinic and contributing, hopefully in a small way, to advancement of collaboration.
That's great. So that's in Boulder, is that correct?
That is in the Denver Metro. We're actually in Aurora,
Okay.
yeah.
In Aurora, okay. Okay, great. So you're a Midwest guy through and through.
Pretty much, yeah.
Yeah. Vikings fan?
From the mountains to the prairies.
Uh-oh. He's hesitating.
Well,
Michigan,
okay.
You can't be a Detroit fan.
I am a Detroit fan. Let's go
See,
Red
we
Hawks.
should have taken Scott to the Bruins-Red Wings game tonight.
Yeah, exactly.
We missed out on
I would
that.
have loved to have gone to that,
So
actually.
tell me, how are the Lions doing this year?
Oh, boy.
Lions?
Wow.
Yeah, I'm sure they're doing really well.
Okay.
See, you could do that if your team was much better, but they're not.
4
So
games better than the last time I looked.
I think they had to kick a field goal to beat them at the last second because they were losing up till that point.
It's a W. You count the W's.
Yeah, more of an ice hockey fan than a football fan.
Great. Well, of course, that good hockey team from North Dakota.
Right, correct. Thank you.
So, get it. Okay, so your area of expertise, right, is primarily dry eye, or
Yeah, I would
You
say
do a lot of different things with some focus on dry eye.
I would say probably 80 to 90% of what I do in any given week clinically is dry eye related. Yeah. So we do a little bit of co-management with cataracts, and that was relatively new to the university as well. That program is expanding, but the majority of my time is taken up with ocular surface disease and cornea.
Right. So did you set up a separate dry eye clinic? Is it structured that way or not?
Yes. So yes, I have a day and a half that's devoted specifically to doing evaluations on referred patients from either other areas inside the eye clinic. We have a pretty big eye center, or community-based referrals. Also doing procedures on those days as well that are ocular surface related. And then the rest of the time it's follow-ups. So, the other three and a half days are follow-ups from dry eye as well as cataract co-management.
Right. That's great. As we were discussing a little bit earlier, the dry eye field is so fascinating today. Even walking around the hall today, it's like, wow. That it's really
The number of booths that are have a dry eye.
big booths. Right?
Yeah. Well, it's changed a lot. I mean, when I came out of school and went into my residency, it was primarily because of refractive surgery, which was really kind of taken off. LASIK and PRK was really taking off at that time, but we generated a lot of dry eye that way, and then not too long afterwards, we really started having paradigm shifts in how we approached it and managed it and understood kind of the importance of inflammation, and then along came the TFOS committees for the first DEWS, the meibomian gland workshop, and more recently we've had DEWS 2, and then we continue to learn.
Right.
So it's really changed.
So in the practice, are there multiple people that see dry eye patients? Or?
So I think everyone sees a little bit of it, right? So in our department we have upwards of about 7 or 8 cornea specialists, and we have 6 or 7 optometrists, including our low vision department, and everyone sees a little bit. But if it's beyond where they're comfortable seeing it, or if it's a more specialized case, those end up getting referred to myself. And then Darren Gregory, who's a cornea specialist, he has a pretty thriving dry eye practice as well. He's been there for 20-ish years or so at the university, so he and I handle the bulk of them.
Okay. So the reason I was asking is that, in these larger facilities, multi-practitioners, do you follow or have you developed a protocol that kind of is the checklist on how you manage it so everybody's dancing to the same drummer? Or?
Well, yeah, so it's always hard to do that with multiple physicians, right? So in my practice, this was key, and I think I started developing sort of like at least a diagnostic routine or regimen that I wanted the technicians to follow probably 10 years ago, maybe even a little bit longer than that now, because that was when we started to see our first diagnostics. And there's an order or a method to the madness. If you're not collecting information in the right order, it actually confounds some of the data you collect later. So I kind of recognized that a little bit early and tried to make sure that the flow made sense from both a patient standpoint and a technician standpoint, but it was something that we could gather data from.
Right.
So in my clinic, it's pretty regimented.
Yeah.
So they go through a step-by-step process before I see the patient.
Right. I mean, it would appear to me that would be a way to evaluate outcomes a lot easier if the process is in place.
Exactly, and we're in the process of doing that now. We have fortunate to have a team of epidemiologists. We're setting up a dry eye registry so we can actually track patients and follow them through the process regardless of whether they're seeing Dr. Gregory and myself or one of the other docs. And we're just in our infancy at really being able to get that going.
Right, that's great. So Jason, that you're known as my co-host.
I am.
So are you going to talk? Or?
Yeah, well, you just have to give me a chance to cut in here, right?
Me?
This
You're
is
doing
May
a
I
great
Interrupt,
job.
isn't it?
You're doing a great
Am I on
job,
the right
Craig.
show?
You're sounding
Yeah.
great. I got all my interrupting in early on. I'm trying to be kind to you,
But I'm bringing you in because you were smirking at me.
I was
thought
smirking
that was a
at you.
signal.
No, it was just the blue light reflecting off your
How was
cap
it
there.
today?
Yeah, right. So I will, because I am curious, because I would love to know, so when you see a patient who's dry eye, which we know is that's such a simplified way of thinking about it. What kind of, when you get done with your workup, what are you ultimately finding? Are you finding that most people it's a gland issue with oil secretions? You find are you surprised at the volume of aqueous deficiency or combo bladders? I mean, what do you see as you work people up? And again, go back to how that changed from maybe 10 or 20 years ago, how you used to manage a patient and how you diagnosed it.
Yeah, boy, that's a pretty long time span. I mean, realistically, when I started really getting interest in this area with patients, it was because I was in Minneapolis practicing, close to the downtown area, and we were seeing actually a pretty large refugee population that was coming in from Equatorial Africa that had really horrible ocular surface disease, and they were all kind of complaining about the same things. Their eyes were red, they were uncomfortable, and that's really actually sort of the fire that got into me to try to figure out how can I help these people, right? So patients come to you, you want to make them feel better, you want to alleviate their problems, and so it started some furious reading. We didn't have a lot of tools back in those days. It was a lot of artificial tears, it was a little bit of steroids, then we got, cyclosporin or Restasis, and that I played around with for quite a long time before I figured out really how it worked. It's not something that necessarily came really intuitively. So it's been, I think, a lot of trial and error over the first probably decade of my career.
Right.
And to answer your question, really, I mean, what am I seeing now? I think that's probably a little bit skewed just because of where I am in a hospital setting. We get sort of like a main line of patients that come from the bone marrow transplant clinic, so I see probably a abnormally high amount of graft versus host. I run our ocular cicatricial pemphigoid coordination, so they see multiple specialists, including myself, for ocular surface care. So we also have we actually have a joint clinic with rheumatology and immunology, ocular immunology, and so Sjogren's patients and people that have, more advanced autoimmune disorders end up in my chair too. So asking me what that looks like, I think I probably see a lot more really kind of severe immune-mediated disease, which actually involves not just aqueous suppression, but it definitely involves, pretty significant negative impacts on the meibomian glands, goblet cell structures, and just some cicatrizing disease on top of it. So
there probably is some interweaving of these different aspects.
Yeah.
Inflammation can have a impact on multiple ways.
Absolutely.
And so what kind of objective measures do you use to diagnose, but then also to follow up on treatment, to know whether, because we know that dry eye doesn't just start one day, you don't wake up with dry eye. It's something that evolves over your lifetime, it builds. Mm-hmm. And like a lot of conditions that take weeks and months and years to build, they don't go away with a medication for 2 weeks.
Right.
So a lot of times we may put patients on a treatment and we might see them back 6 or 8 weeks and they might come back and say, I don't think this is doing much, doc. I mean, how do you determine whether it is doing anything or not, other than just their comment, which, as we know, sometimes isn't the best measure?
Well, I think one of the first things is your frame of mind really has to be constantly challenging yourself and what you think you know. So I think that's really where it starts. So we have great diagnostics, much better than when I started. Obviously, we've got meibography, we've got osmolarity, we've got MMP9 detection. We still have things like tear volume assessment, tear meniscus height. I try to get as much of that information as I can, in addition to even things like corneal sensitivity, which I didn't necessarily think was super important, but the more patients you see, especially in the realm that I'm in, we're finding a lot more people that have neurosensory dysfunction as well. That's probably contributing to decreased tear flow. So I think the first step is try to get as much information on about the patient as you can using as much available diagnostic criteria. But then when you start them on a treatment plan, which foundationally involves trying to rehabilitate the meibomian glands, trying to calm down any inflammation, making sure that they have access or how to use their artificial tears for comfort from time to time during the day. Those are all foundational things that most patients I think would benefit from. When you see them back 6 weeks, 8 weeks, if they're saying they're not feeling better, you have to kind of take a step back and say, okay, well, did I miss something? Is there something else that I'm not taking into consideration with this, or do we just need a little bit more time with this? What are your symptoms like? Is one eye worse or better than the other? What time of day that your eyes are at their worst? All of those things, I think, really help kind of nail down what the problem is. And so as I've gotten better at taking better history and taking a look at the diagnostics and challenging myself, I think it's helped patients.
Yeah. Now, one of the things you brought up, and I thought, and I've heard this before, and I just haven't thought about it lately again, but corneal sensation. Is that potentially a much bigger part of this whole picture than we've ever given it credit for? Is that possible? B, is anybody working on some objective ways of measuring that actually quantifies something?
So those are really important questions. And the answer to the first part is absolutely yes. So I think the neurosensory system and dysfunctions there actually contribute to a pretty significant amount, because we have such a codependency of the epithelial health, but then also the feedback mechanisms that monitor from an external environment, upregulation of tear secretion. All of those things really are kind of driven through neurosensory feedback. And
through refractive surgery, we know what that does. We know if you put a scleral lens on your eye, you decrease tear production. If you have a neurotrophic event or whatever, you're going to experience dry conditions. Contact lens wearers too. I mean, we know that chronic contact lens wear can create a little bit of perhaps a desensitization of the cornea. And is that, we do see a lot of times contact lens wearers blinking less and things like that because they don't feel it, and they develop habits of, again, another aspect of dry is blinking. Yeah. Which I think, again, critical. Is way underappreciated, how that influences the bad habits we develop over our lifetime when it comes to blinking.
Absolutely.
But anyway, sorry to interrupt that.
Well, it's the name of the show.
Right.
I kind of expected it.
Yeah, a little bit. The question is after I interrupt, can you remember what you were saying? Can you keep your train of thought through it?
I hope so. So neurosensory aspects of it, are there ways that we're actually addressing that or studying it? So the thing is that I think neurosensory malfunction, dysfunction is probably a pretty significant percentage of what we're seeing. Now, in some patients, it's desensitization or decreased sensation, so kind of movement towards neurotrophy, although maybe you get into kind of a messy gray area there. But then you have the folks that go in the opposite direction, where they become hyperesthetic or increasingly sensitized, which we know happens when you put inflammation around the nociceptors in the cornea. So we are a part of a 23-site nationwide trial that's looking at that. It's called the Nassau study. It's our PI is out of Tufts University. It's actually non-funded, but it's the first attempt to try to quantify how much of that neurosensory dysfunction is really a part of what we're seeing as dry eye.
That's great.
So,
yeah, I think that's a whole new realm of objective testing that's waiting for us to figure out, and then utilize that in the diagnosis and management too. So.
Yeah, absolutely. That to me is probably one of the more exciting parts about it. And then, in addition to that, we can actually correlate that with what we see in the corneal nerve architecture through confocal microscopy, because that's another part of what we do for select patients in the dry eye or ocular surface clinic. So.
Right, and you have the opportunity to do that when you're working with advanced cases. Most clinicians are not going to have confocal in their offices, but knowing, that's an aspect of it too. It's important.
Yeah, exactly, and I think it just contributes to the greater body of knowledge of what we're ultimately looking at, maybe driven through a neurosensory problem.
Right. So, do you think, coming from a relatively dry area in Minnesota to another dry area in Colorado, you always hear about dry eye being, the incidence of it being so much greater in Colorado. Is that a fact, or is that anecdotal?
No, I think there's definitely truth to it. I mean, we would see it definitely seasonally in Minnesota with the winters being so cold, and a lot of the moisture gets sucked out of the air there. But so we'd have patients that were on more seasonal directed therapy, and in the summertime it's relatively humid. And people spend a lot of time outdoors there in the summertime, of course, and in Colorado, our summers are just about as dry, and then we have fire season, which this year went from beginning of July all the way through mid-September, where we had smoke.
So you're saying
and
hot air
particulates.
contributes to dryness?
Well, I
Is
don't
that
know.
why I always feel dry when Craig's talking to me?
I think that's a
My
totally
eyes get
different
all-
mechanism.
Oh, I didn't.
We'll notice if Scott starts rubbing his eyes here in a couple of minutes.
I
if
think
that's
you're-
true or not.
Rubbing
Depends
my
who's
eyes
talking
and
at
rubbing
him.
my head, I'm not really sure. But definitely we see, I think, it being a more year-round issue in Colorado with lower humidity, and then again that period between July and September where we're dealing with a lot of particulate matter in the air, that just exacerbates inflammation, makes everyone kind of miserable, even if they're doing well on therapy beforehand.
Yeah. So you utilize different tests as we're talking about to analyze. Are those driven downward towards the technician or assistant, or are some of these tests that, some of the instrumentation tests and so on, you're doing directly yourself? Or
Yeah,
how does that operate?
Yeah, most of it is, I try to make it as much technician driven as I can, as long as they have the workflow down and understand why we're doing things the way that they are. And so, we recently changed the technician that is working with me, and she's great. She's very eager to learn about a lot of this stuff, and I want to have it make sense to her as to why we do the things that we do. And to get, when we're doing things like myography, get good quality images, because it doesn't help if we're getting little snippets of the glands. We want to really be able to image the whole thing.
Right.
So, but I try to make it just from my standpoint, I try to make it as much of that as tech driven as I can, just because my part of the examination is still probably 10 minutes or so, 7 minutes, but then I can spend time going over those results with the patient so that they understand. And while we had this kind of shift a little bit because of COVID, for a while I was working with a medical educator that would also kind of reinforce some of the basics, so I don't have to tell patients how to do a warm compress 10 times, 20 times a day, right? So, because that does take a lot of time.
Yeah. Right. So let's shift to treatment. We talked a lot about the diagnosis, which of course is critical. Having the right diagnosis, you're much more likely to get the right treatment. But and then again, breaking apart the dry eye categories. So let's not talk about your advanced severe ocular surface disease patients, because they're kind of unique to you and your setting. A lot of practitioners aren't going to have that patient population. Let's talk about your dry patients. I'm sure you're at a university, there's people that just work there whose eyes are dry and they come see you, or people from the community whose eyes are dry and they don't have. What do you find is effective? I mean, what are some of your favorite strategies for trying to manage the different types of dry eye?
So, number one, I think finding out how long it's been a problem for the patient is helpful, and the longer that they've had an issue with it, the more likely they are going to get immunomodulatory therapy. So, or Restasis or Xiidra or Cequa, whatever your particular flavor is, I think those are still really helpful from a foundational standpoint. Most practitioners, I think, probably don't quite give the correct instructions on warm compress therapy. We want to make sure that they're doing it for 10 to 15 minutes. For a lot of patients that have kind of mild to moderate MGD, that can be a lifesaver just by itself. Addressing, blink deficiencies, certainly with as much time as we spend on the computer or, electronic devices, making sure that they're taking breaks, doing things like conscious blinking, so anytime their situation changes, they do 1 or 2 blinks to try to overcome the big period of time in between where they're not blinking. And then, if they're the type of patient that's waking up in the morning and noticing symptoms right away, then, having them try to figure out, well, we can kind of tell, I guess, because of some of the blink data that we're collecting, what the correlation is between that and nocturnal leg ophthalmos, but addressing those types of things with protective mechanisms, whether it's a sleep mask that's lined maybe with just a tiny little strip of saran wrap, to something more elaborate like a sleep goggle or ointments. I think those foundational things, are helpful to a pretty broad percentage of the population with dry eye.
Along those lines, and this is something else that sometimes comes up, what about the notion of shut eye time? Do you ever factor that into your management? What I mean by that is, there's a lot of people that only sleep 5 hours a night or less. And so that means they're probably eye open 19 hours a day.
Yeah.
And I really feel, at least from a personal perspective, when I'm lacking sleep, my eyes are more vulnerable to feeling dry because I've had less of that shut eye time. Right. And is there benefit? I had somebody recently who has a significant degree of dry eye and insomnia. So if you can't sleep, I understand, but close your eyes as you're awake.
Yeah, so again, that's part of the history taking that we're doing. So just as kind of a checklist as we go through it, we ask about history of migraines. One of the questions is, what is your average amount of sleep that you get per night, and is it restful or not?
And has that ever been...
We haven't done any retrospective analysis
yet. It'd be interesting to see that. Yeah.
But I think that, for sure in the patients that are saying, well, I don't really sleep well, and I'm getting maybe 3 or 4 hours a night, I think, in those patients we're really kind of directing them to, maybe we should be looking at this maybe through a sleep study or at least a letter to their PCP to talk about those things and addressing potential protective mechanisms. So,
do you fit contact lenses yourself?
I don't.
So it's part of the treatment when you do turn to contact lens systems to aid in the treatment of scleral lenses.
Yeah,
so that's moved over to a different department.
Yeah, so that's been a really interesting collaboration, just because I get to the point where when I'm offering that to the patients and we set up the appointment for them to see our contact lens specialist, and I usually will send a letter or a note along with it saying, this is what I kind of think would be beneficial, and take it from there. Those patients, generally speaking, actually do pretty well with them too. Right. So it is a service that we offer, although I don't do it myself.
Right. That's a pretty cool system.
Yeah. Talk, if you will, again, just a little bit about the treatment options and maybe moving more towards in-office treatments that you guys do that you find effective.
Sure. So I've worked with a number of different treatments. Up until recently, we were doing quite a bit of lipid flow. I've done meibomian gland probing. I had access to IPL when we were at Minnesota, and we're still trying to work that through the hospital system in Colorado. And then I've done quite a bit of work, just sort of freelance, I guess, a little bit with the tear care system. So a lot of meibomian gland oriented procedures, and I think those can be really helpful. I do think there's probably a little bit of a difference, at least the patients that I track towards something like IPL generally have a lot more lid inflammation, and so I think those patients did really well with that as an initial therapy, and then may still benefit from expression along with it. But addressing the meibomian glands is still a really helpful part of what we do.
Yeah, I think at our dry clinic at Indiana, I think our IPL is the most used instrument in the office. I think people really do like it, and they do find it helps. So I think those treatments are certainly viable for a lot of patients.
Although it's a smaller number of patients and there's not really good peer-reviewed data to support it, meibomian gland probing has actually been really helpful for a lot of patients too, and that's a little bit more, I think, technically challenging. It certainly takes a bit more time. We have to numb the lids using a topical anesthetic and then use a probe to basically just go in maybe at 2 millimeters or so. But a lot of patients do seem to get relief from that too, although it can be a little bit uncomfortable still, even using a topical anesthetic. And again, we're still trying to build, the literature around that, and whether it's truly helpful or not.
We've got a couple minutes left, and I was just wondering if maybe, because you do a lot of dry treatment, if you got maybe just a couple pearls, like I don't know, before I do a LipiFlow, I'll send the patient home with X therapy for 2 weeks first, or anything that you do that you find maybe helps that a lot of people haven't thought to do?
Well, I think when we're doing meibomian gland procedures, or really any procedure in the office, the more invasive it is. This includes probing. It probably includes LipiFlow to some extent. It certainly includes any kind of manual expression where you're kind of mashing on the lids a little bit. I think steroids for a week or two afterwards makes sense.
Afterwards? Okay.
Right. I don't always start it beforehand, although most patients are on some type of immunomodulatory therapy beforehand, like Restasis or whatever.
Sure.
But afterwards, I think it makes sense. I mean, cataract surgery these days is a pretty not non-invasive, but it's minimally invasive. I mean, we're talking about a 2 millimeter incision, and we still stir up quite a bit of inflammation internally, but we don't really have the same measurement tools, or we haven't really looked at it the same way in lid procedures, but I think it probably makes sense that we're generating some type of inflammation there. So I've always thought it made sense to do a week or two of steroids afterwards, something that's kind of mid-level, like a loteprednol or something, twice daily for 2 weeks. A minimal IOP response with those sorts of things, and I think it helps patients recover a little bit better.
And have you ever considered or done this with a patient where you just did a intermittent pulsing of steroids? Take 3 times a day for a week, every 6 weeks for a week, and just chronically, rather than having them go on forever.
Yeah. So
short term.
So I'll allow pulse steroids for sure in patients that we're finding maybe aren't really well controlled with chronic therapy using like cyclosporin or lifitegrast. Although if they're feeling the need to do it, we're talking about dry eye flares these days. If they're feeling the need to do that, more than, or maybe once a month or more, I think it probably makes sense that we need to adjust some other aspect of their therapy. So.
Okay, that's great. I mean, really, it's very interesting to hear exactly what's going on with you and at the university. Is there any question that we should have asked you that we haven't? That is something burning you would like to share with the audience?
Something burning that I like to share? Well, again, the golf balls are great, although now that you mentioned that they're high speed, I'm kind of afraid to use them because my shots can go anywhere, and I really don't want to hurt anyone with that.
They just go farther out of bounds.
Farther, right, I was going to say.
Farther under the road. That's next to the golf course. No, I prefer red wine over whites generally.
Okay.
Yeah, kind of an old world guy versus new world.
That's an excellent tip. I've been thinking about one myself.
Go for hockey over fighting Sue, of course,
exactly.
right?
Exactly.
Get the important things.
To our audience, thank you for watching. This brings to a close this episode of May I Interrupt? We had a phenomenal guest today, Dr. Scott Hauswirth. My partner, Dr. Justin Jedlicka, was, I'd give him a solid 5 out of 10. And so
pretty good for me.
It's your top number.
I think it is.
And please stay tuned. We're coming to you from the American Academy of Optometry, and we are going to have more of these episodes
May I interrupt?
Really interesting people.
May I interrupt?
No, you may not.
10 out of 10. Would do this again.
Okay, you're vying for Craig's spot. I vote yes. So.
Exactly. And for my last episode, I would like to thank you for participating. Take care, everybody.
Bye.
Thanks, guys.
Thank you.
Yeah.